Our next presenter will be Professor Sonia Hernández-Díaz, who spent her life studying drugs in pregnancy, and she will guide us through the thinking how we can put this together in beginning to answer the question of what kinds of studies are really called for. And Sonia, that's the button.
Thank you. Thank you, Alec. Hi, everybody. So I'm going to talk about what we know, what we want to know, and I'm going to walk us through a design of a potential study to answer what we want to know. And finally, I'm going to connect with the panel on where do we go from here. So starting with something I think we know and we will all agree is that we want to avoid acetaminophen in pregnancy unless its use is medically indicated. That will happen with all the medications, and I will argue with medications outside pregnancy as well. But of course, in pregnancy, we in particular will have zero tolerance with unnecessary harm to the mother or the fetus. And the reality is that some mothers need pharmacologic treatment for their conditions during pregnancy. And in some cases, the benefits are going to outweigh the risks, but we still need to know about these risks. And one challenge that we have seen today about these risks is the heterogeneity of the findings that we have and the designs of the studies. So Krista reviewed how we have different treatment strategies, the timing in gestation, the duration, the frequency, the dose, the concomitant medications, the formulations with opioids. We had also different definitions of autism spectrum disorders, when in childhood, which relates with the follow-up of the studies, the severity, the types of autism. And we also had different methods to ascertain acetaminophen with prescriptions, with over-the-counter medications, dispensations, maternal recall, and different sources of information for autism spectrum disorders as well. The symptoms onsets were different. The clinical versus maternal diagnosis were different across the different studies. So what we learned throughout the studies is that the indication is crucial. It is important when we talk about actions and recommendations. We saw how short-term use doesn't seem to overall have evidence for a risk, and that's what we use for fever. But if it is for more longer-term uses like migraine or pain, then the question is what is the alternative treatment that we are considering. And indication also has implications for us to get valid designs. And we saw how genes are an important consideration because they are a strong risk factor, but they have to act as a confounder because they are associated with the utilization of acetaminophen through indications like migraine. And potentially, the mother having migraine might potentially also affect the surveillance and diagnosis of certain types of autism, like those associated with hyperactivity potentially, right? And we also saw from Brian's results how when the study started with a relative risk of 1.26, adjusting for all the confounders, and as the authors acknowledge, might not be perfect confounding adjustment, it moved all the way to 1.05. And then with the ceiling design, very similar results dancing around the null after taking into account these confounding factors. So we have inconsistent findings, and we also have, when there are associations, relative risks that are below 1.2. And some decades ago, there was a paper in epidemiology saying that we can really not trust those relative risks below twofold increased risk, and twofold may be too much to us, but where is our threshold? Is it at 1.2 or 1.1? And the thing is that because there is a large number of pregnancies exposed, even small associations are going to be relevant. I have to acknowledge that. But the difficulty is when we are talking about a small relative risk, then they can easily be explained by systematic errors. And we know that if we cannot conclude that the association is causal, then we cannot do recommendations based on that. Another thing that we learned today, and we probably knew from before, is that it is dangerous to select results that fit into our story. And we saw an example of how males had an association of a beta of 0.63. Females had an inverse association, but because the females, the protective effect was not part of the story, that result was not used in the recommendations. Another thing that we know is that even if we were to know that that association with autism is causal, the risk of autism is not the only thing to consider. We need to consider other risks, we need to consider the benefits, and perhaps other considerations as well, so that we cannot jump into recommendations based on only one of our studies. We can see how today we may be discussing the evidence, the data, each of the papers, or the selection of the data, or the interpretation of the data, or the recommendations. And I think the discussion is going to stay in the lower part of the ladder of inference. So we have discussed how association is not causation. Brian reminded us of that, but I will push it one step further. Even if we had good studies showing causation in the studies we discussed today, the studies did not evaluate alternative treatment strategies, so they didn't directly inform treatment decisions. And if so, what is our question? What is the specific questions we have that will inform treatment decisions? That will be something like comparing treatment A versus treatment B for a patient X weeks pregnant with disease X. And so let's design a study to answer those potential questions of interest. And to design the study, I'm going to use the target trial framework. So we are going to go through each of the protocol components that we will have in a randomized trial, and then we are going to do the same, trying to emulate that same design using observational data. So going with the eligibility criteria, I'm going to propose one study. You may have modifications in mind that are going to be as valid. So eligibility criteria, we have the population of pregnant women. Yeah, let's say that we enroll them when they come to visit around 5 to 35 weeks gestation with a clinical diagnosis of migraine, if we focus on that indication, because we have seen that is long-term what we are worried about, and that are not taking opioids. Then we are going to define our treatment strategies of interest. For example, we can compare acetaminophen for at least 20 days versus an alternative treatment for migraine, let's say triptans or ibuprofen for the same amount of time. We can decide that we are going to not allow those that are taking opioids, for example, and that after those 20 days, we can allow them to take the treatment as needed. And regarding the assignment procedures, the randomized trial will randomize the treatment strategies, and therefore we will have balance in the timing of treatment initiation during gestation, and on the different risk factors such as genetics, family risk factors, individual risk factors such as some mental health or psychotropic use during pregnancy, and other potential confounders. Then we will follow everybody from a predefined number of years, let's say 10 years, with systematic clinical evaluation of autism spectrum disorders, say every 6 months, and then classify them based on severity, on symptoms, on type, maybe on the presence of intellectual disability. And for the analysis, we can do an intention to treat and the per protocol, considering the adherence to treatment. We can consider fetal losses as a competing event, for example. That can be part of another symposium. And then apply censoring weights if we have losses to follow up during pregnancy or childhood. And as usual, have our cumulative risk curves. And we can have predefined secondary analysis of interest that will stratify by gestational age at initiation, for example, to kind of pinpoint potential etiologically relevant windows, consider severity and the type, and look, for example, at effect modification by sex of the baby. And so why don't we have a clinical trial like that already, right? The main reason is that clinical trials typically exclude pregnant women, and that it will be, in any case, probably unfeasible to conduct a clinical trial to demonstrate a risk or safety, and it will be logistically complicated to follow the children for 10 or more years. So most likely we have to do an emulation of this trial in observational real-world data. So I'm going to go through each of the steps of the protocol, but thinking about how can we do that with observational data. For eligibility criteria, we mentioned that we want to have specific indications. Most studies didn't focus on that, but we could do that. For the treatment strategy, we said that we had a specific timing in pregnancy, a specific reference group with an alternative treatment. And many studies didn't have that, but we can do that in observational data. What is challenging is obtaining the information in observational data, as was mentioned, to classify the use of acetaminophen at each time. So that's going to be a challenge that is going to potentially lead to misclassification when we use the observational data. The assignment of the trial was random. We don't have that in real-world settings, and that is going to bring confounding. So we can try our best to adjust for confounding and then triangulate the effects doing, for example, sibling design. If we fail to do this completely, we will have residual confounding. Then we'll have the follow-up that will can also define in the observational data. Many of the studies did not set a specific time of follow-up to report or project their cumulative incidences. The outcome, we can also predefine the outcome that we want to identify. Is going to be challenging to obtain from observational data all the detailed information or clinical information that we may want to have, and potential misclassification if we need to use codes or if we need to use maternal report might lead to, yet again, more misclassification. The analysis, we can also do survival curves, like a clinical trial would do, and specify our secondary analysis ad hoc, not to get into that potential selective reporting of certain analyses that fit our hypothesis. So we went through the whole design. We saw some things that we can do in an observational study. We can specify the indication, we can specify the treatment strategies, present our survival curves. We also identify the main challenges that others have repeated before me today. And that is the challenges of identifying the use of acetaminophen, the timing, the duration, to define a comparable reference group and ascertain the autism spectrum disorders systematically. And all of those challenges, if we fail to do a good job, will take us to have misclassification and confounding. And the trick here is that most likely the confounding is likely biasing up, and the misclassification is likely biasing towards the null. So my conclusion is, don't try this at home. This is very challenging. We can do it because we have the numbers, but it is hard to have a valid study. So where do we go from here? Can we do better studies or analysis of the studies that are already available? I think that a randomized trial is going to be probably infeasible. Doing better observational studies that the ones that have already conducted, I think is going to be difficult. We have the Swedish data, the Danish data, the MOVA study, and others that probably have the best data that we can have. So could we use those data to do more analysis and go deeper in certain things like exploring sensitivity windows during pregnancy? And could we do an analysis following the target trial emulation? And would that help define the question and perhaps reduce heterogeneity and even some biases? And if this is as good as it is going to get, is it good enough? Can we conclude whether there is a causal link or not? And it is my personal opinion that it is very challenging to decide that when we are talking about differences of plus minus 5%. So to leave you with another thing, I think we will agree, and in a positive note, if we approach this acetaminophen saga as what can we learn from it? Why did some studies find an association? If acetaminophen was not the cause, what was it? And we mentioned it can be chance, it can be biases, it can be confounding. If it is confounding, and if it was the migraine, the pain, or other indications, can we follow the clues? And I think an important thing that we will all agree is that it is important to continue doing research in autism to identify modifiable causes and reduce the burden for the kids and the family. So thank you very much.